this applies for both colon and rectum. When we look at the mucosa, we still have a simple columnar epithelium. Microvilli are present. Goblet cells are definitely present. Increased in number, approximately 25%, though they look much higher. Ana muscularis mucosa. So what we see are simple glands. I'm not even going to bother doing the columnar cells on there. The straight intestinal glands. So you can see that we don't have a lot of surface area. Why do we have so much more goblet cells though? We have that much more protection that we need all this mucus for?
They need to lubricate.
Exactly right. Here the mucus is not for protection against acidity or digestive enzymes so much as it is for the protection of the drier fecal matter. Anybody that's been constipated knows how painful it can be, or if your kids are constipated. I had a student last semester who had a developmentally delayed daughter and was talking to me about her problems with constipation, kind of compounding themselves. It hurt to go to the bathroom, so then when she needed to have a bowel movement, she wouldn't. And so, of course, the longer she held that, the more water was absorbed, and the harder and sharper the stools became. And she just became more and more afraid. It was just this compounding series of events. And so I suggested in consult with her pediatrician that he provide some stool softeners so that it made it less difficult and less painful, and she learned, instead of holding it, she would learn to go to the bathroom when she needed to. So the goblet cells provide a lubrication. I usually tell a story here of a patient of mine. When I was in graduate school, I worked weekends at the hospital every other weekend, but a friend of mine had a patient. She was a home health nurse, and she had a patient in Davis who needed to have high colonic enemas. How many of you, we don't have to raise your hand, have had a Fleet's enema? Something you can buy in the grocery store. Sometimes they'll give it to you before you have childbirth. But it's just the most 2 cups of fluid, usually about 1.5 cups. And with a short little nozzle that you place in the anal canal, and it helps to add fluid to fecal matter and flush out. Obviously, if you've had a colostomy, they flush out a lot more than that. Well, the only way he could have a bowel movement was to have high colonic enemas. When he was about 5 years old, living in not Southern California, but Southern Central California, just above north of the Grapevine, he would play outside in the fields and he ate lima beans. I don't know who would eat lima beans anyway, but these had been sprayed with a pesticide. Somehow his esophagus and his stomach and small intestine healed, but he completely burned out the lining of his large intestine. And between the scar tissue that remained and the lack of goblet cells, once his absorbed food got there, it stayed. And so from the age of 5, the only way he could get rid of fecal matter was to have these colonic enemas. When I met him, he was 82. He had become a veterinarian, had gone to World War II taking care of the horses and the cavalry over in Asia, had become a public figure, political figure, and this is the way he went to the bathroom. Every 2 or 3 weeks. He was so busy. Now, you should have a bowel movement every 1 to 2 days, at most 3 days. Every once in a while, you might want to go 3 days. But if you've gone more than a couple of days without a bowel movement, you know how uncomfortable that can feel. Well, he would get really busy with his political work, and in Central California, he had a special bathroom built into his house And as a child, he would have this done more often, but as an adult, he just got too busy. So the first time I met him, the front bedroom was not their master bedroom, but where he would have this done. It had a bathroom off. And so he pulled off his shorts and his underwear, and I proceeded to, he had a glass jar that would hold about 2 quarts that looked like a blender with a rubber hose that stretched over it, latex, and about the diameter of my finger. And I'd mix up 2 quarts of just warm tap water and lubricate the end of the tube. And he thought because I was an anatomist, I could do a really good job because I knew where things bent and turned. I just went slow. And I could actually feel the end of the tubing at his transverse colon, how high we went. And there was just a pinch clamp on there, and I would let it drain. And I would do this several times until he had between 8 and 10 quarts of fluid. And we're talking the normal enema is 1 to 2 cups, okay? So he would have between, and I'd see his toes start to curl, and I'd say, okay, you can go a little bit more, a little bit more. And then he'd say, okay, that's enough, and he'd go to the bathroom, and I'd sit, and for about 15 minutes he'd be on the toilet, and I'd be reading my research papers. And then he'd come back, and we'd do this a couple more times, and then I would switch to soap set. I'd just take some ivory soap and lather out my hands and rinse them in the water. And we'd do that 2 or 3 times, and then we'd finish off with normal saline. I'd just take some table salt and measure it into, this would take us from about 6:30 to 11 or 11:30 at night. And the first time it happened, he pulled on his shorts and came out and sat on the bed and was writing me a check, and I just started giggling. And he said, what? And I said, do you know what this looks like? So he was very careful to write RN after my name every time. And his wife would just busy herself with stuff in the back. And I said, why don't you have your wife do this? And he said, because she's my wife. And you know, she didn't marry me to take care of me, and so his entire life he'd had nurses, whether he was in the army or whatever, orderlies. And I said, well, why don't you just have a colostomy? And he was very grateful that he didn't have to have that done. He could take care of it in this fashion. But he would get busy and just, you know, not think about it until the toxins started to build up in his body. But when he was a child, he had an aunt who also had to have the procedure done. So she was in her mid to late 20s, and it made it easier for him to deal with it. She had actually, her fiance, they were going to go out to a date and dancing at the local fire station, and he was late, 30 or 40 minutes late, and her friend said, you know, he knows where the dance is, just come with us and he can join you there. And so she did, and he did. And while they were dancing, he shot her in the back with a small pistol through her spinal cord and paralyzed the autonomic nerves that control peristalsis. And so she had a paralytic colon, and things just wouldn't move through. And so she had to have the colonic enema as well. And so he told me that it just made it easier for him as a child. And when he grew up, of course she was a paraplegic. When he grew up, he would travel with her and carry her in and out of the bed and breakfast places, and she had a caregiver that would do those procedures for her. So just really ill and down. He did have scar tissue, of course, but he also had been stripped of this mucosal epithelium, and it just illustrated very well the purpose of the lubricant of those columnar, those goblet cells. Okay, we do have our muscularis mucosa. We have a standard submucosa. So when I say standard, nothing new, just is your regular connective tissue. And now, what would the modification be to our muscularis externa? I've already mentioned it. Pardon? The 3 bands, exactly. So we're still going to have inner circular layer. And we're going to have an outer longitudinal layer, but it's limited to those 3 bands. The tinea coli. Okay. And we have a serosa. So the ascending colon and the descending colon are only going to have a peritoneum on their anterior and partially lateral surface, while the transverse and sigmoid colon would have the serosa completely wrapped around them. This is just a posterior view showing how the posterior Taenia coli leads directly to the appendix. So if you've got a surgeon in there kind of fumbling around and can't find his way, just remind them to find a Taenia coli, and that would lead them to the appendix. All right, then. Leads us down to the anal canal, and then we'll take a break. So, anybody want pictures? There's not a lot of material up there. Without going through the entire format, just some reminders. With the anal canal, our epithelium now is a non-cornified stratified squamous. So again, we have a sudden transition from the intestinal glands and simple columnar of the rectum to the non-cornified stratified squamous of the anal canal. And for our last sphincter, we actually have a pair. We have smooth and skeletal, which we didn't see with our skeletal at the mouth. So we have an internal anal canal, internal anal sphincter. And an external. Anal sphincter. Okay. So with our internal anal sphincter, the sequence of our defecation reflex is identical, essentially, to the micturition reflex as far as the stretch receptors and the inhibition and so on. So with our internal anal sphincter, is that going to be controlled by voluntary or involuntary neurons?
Involuntary.
Involuntary, because it's smooth muscle. So what is going to keep this constricted? What would be the nerve, sympathetic or parasympathetic, that would keep the sphincter contracted?
Parasympathetic.
Oh, sympathetic. So these are going to be sympathetic, and it's going to be our sacral splanchnic and also hypogastric nerves. We've been dealing primarily with the splanchnic, so that keeps it constricted, all right? Then as fecal matter moves down the rectum, it stretches out the rectal wall, not the sphincter itself, but the rectal wall, and that sends sensory neurons back to the spinal cord. If you're ready to go to the bathroom, then the sacrosplanchnics are going to be inhibited, and pelvic splanchnics allow it to relax. and pelvic splanchnics are also going to cause peristalsis to move the fecal matter through the rectum. Okay? So peristalsis of rectum. Now, if you're potty trained, as we all are most of the time, we need the external anal sphincter. To relax. So what's keeping the external sphincter constricted? No, this is skeletal muscle. So yes, it is the same as the urinary system. What innervated our external urethral sphincter? Pudendal. And that's kind of where we left it because we didn't go much farther than that. But for this, we can go a little bit farther, the inferior rectal nerves of the pudendal. Okay, they actually, you can see them in some of our models going, so pudendal nerve. So those are going to be, when you have to go to the bathroom, those would be inhibited and allowed to relax. So the external anal sphincter is a component of the levator ani. Remember our pubococcygeus, puborectalis, iliococcygeus. So it's a portion of that puborectalis that forms the levator, that forms the external anal sphincter. So I'm not going to go through the sequences because we did that for the urinary system. We didn't keep the same, but that's a basic outline of those components. Also review, I'm not going to do it today because I don't have time with the liver and the pancreas, but make a note to yourself to go back and review the middle and inferior and superior rectal veins. Remember our hemorrhoids? And internal hemorrhoids are due to varicosities of the middle rectal veins, and external hemorrhoids are due to varicosities of the inferior rectal veins. So it's been 6 weeks, not that long, has it? Since we looked at those structures. Okay, take a break, stretch, and come back in about 15